Perfect. So it's 9 o'clock. So I guess we'll get going. By way of introduction of the topic, I think everybody knows who I am. I thought it was time, given that the rest of the world is in its second wave. Hopefully, we're not going to see what the rest of the world and indeed Canada is seeing. But I thought numbers are bumping, even locally. It's probably time to refresh our knowledge about our algorithm so that we can nail down the important clinical management principles. B, sort of introduce anybody who's joined us since the spring, and there's a number of people who have, so hopefully just introduce them to the algorithm. Is that my own voice coming back at me? Is somebody not muted? Maybe it's just because they're logging on. And B, sort of review the evidence around emerging therapeutics with benefit, because that's something that's changed fairly dynamically since the emergence of any therapeutic suggestions in March and April. Oh, what's going on now? There. One thing I thought worth reviewing that seems exceedingly basic is the symptoms, but I think we've all recognized. Somebody's not muted again.
I have the power to mute. I will be muting people.
So distracting. Is the symptomatology of the disease process. It's something that we sort of have gotten into habit a little bit of brushing off. Do you have any symptoms of COVID-19? And then people end up sneaking past the screener, maybe triage, maybe us. And then we're like, oh crap, they need a swab, and they've been here for however many hours they've waited as a C-test 4 or 5. Given what's going on right now. And so a refresher of the symptoms, and I think it's a tiny bit important to notice that different jurisdictions have different lists of symptomatology, but they're all sort of fairly similar. So on the left are listed the New Brunswick symptoms, so fever, cough, sore throat, runny nose, headache, fatigue, myalgias, diarrhea, loss of taste or smell, and in kids the vasculitic rash. Public Health of Canada has a slightly different list, and I'd say that the only thing that's a little bit worse is shortness of breath or difficulty breathing, which makes intuitive sense in a disease process that we know is causing primarily respiratory complaints and pneumonia. But just that anybody with any one of these symptoms needs to be immediately isolated, in whatever capacity we can do that, and put on droplet contact precautions, which includes closing the door of the day room. It doesn't make sense for us to do all of this other stuff and then just let them hack and cough all over the department. And I think that it behooves us all to participate. It's no one team member's responsibility. We all know that stories change over time and evolve, and not everybody is forthcoming the initial time that they're asked. And so anybody along the course of treatment can institute this, and it's best for the provider, but it's best for our whole team, especially given what's going on right now. And so I did do some updating. It's not posted to the website yet, but I'll forward it to Mandy when we're done. I just wanted to make sure that there was no suggestions that people wanted to input before Mandy went through the efforts of reposting it to the website. But this is our updated clinical treatment guidance algorithm for COVID-19. It went through a number of iterations in the spring, and then it got real lax over the summer while we were not seeing any cases and evidence was just starting to come out. But it's updated now, and we'll go through. Obviously, it's fairly overwhelming if you just look at it like this. But we'll go through the pertinent sections, I think, that are relevant for update and refresh today. And the sources that I've used to compile evidence suggestions, guidances, what have you, are listed on the side. And so it is evidence-based. It's not just what Cherie made up. Briefly, people who have mild symptoms or even moderate symptoms, but they're otherwise well and have a relatively normal chest x-ray, and that means less than 25 to 50% mnemonic change, could probably go home. The things that we need for them to be able to go home is that they have to be able to walk about 30 meters, so your sort of standard road test, which is a little bit difficult if they're isolated, but the COVID corridor is a good little test, and maintain their oxygen saturation greater than 94%. they also have to be living in a situation where if they decompensate, they can return and they can keep themselves well while they're isolating. So they have to have adequate access to food, water, and shelter. They have to have telephone, and they have to have a reasonable adult who could recognize if they're getting sicker and bring them back. When they get discharged, they should receive sort of a number of documents preferentially. And I think almost everybody's getting their MyGMB info so that they can access their own results online. And that ability has been extended to parents of children most recently, which is super duper helpful. And that will help to lessen the burden of incoming calls to our ward clerks, which is already exceedingly too much. And if you don't know how to do that, the information sort of in that center box, I couldn't without compromising the safety of the patient information on the tracker, sort of screenshot the process. But if you go up to the printer icon in the header of I3, and then on the drop down menu in that pop-up box, click patient info and go slide down to my GMB, click print, it'll print it on the printer on the 10 to 18 side. And I think anything we can do to sort of offload non-nursing duties to our stretch nurses right now would be helpful. And that's something that's fairly easy and straightforward to do if you know how to do it. It's just if you don't know where it is, it's a little bit tricky. Additionally, it's important to review with patients who you suspect of having COVID-19 or going home how to properly self-isolate. And if they aren't educated, then mistakes are going to happen, and that's how community spread is going to happen. So in our SOP on the website, as well as public health for the province, they have their handout, which is there listed on the left. And accompanying our SOP and our algorithm, we also generated some discharge instructions in a printed form that you can give to patients to take home, because they'll be overwhelmed with all the other information you've given them. They're probably not going to hear all the words, so some written documentation is always helpful. And for those that are not well enough to go home, so moderate patients who have more than 25 to 50% bilateral infiltrates that look like COVID, or those with at-risk conditions you feel would be better served in hospital. And we treat them more like they have severe disease and cohort their investigations thusly. And everybody gets a nasopharyngeal swab. These patients have already had a chest x-ray. They probably warrant some risk stratification with additional investigations, including sepsis bloods, blood cultures, LFTs, and that allows you to do a SOFA score on them, and gives us all a working framework for who should be looking after them and how at risk they are for decompensation. And then that brings us to the sort of general treatment options. So it's a viral illness, so supportive care is the mainstay of therapy. There's some emerging therapies we'll talk about the evidence for, but supportive care is not really necessarily the most helpful phrase in the world. And what we know about COVID-19 so far will help to sort of fine tune that supportive care suggestion. And so in terms of mitigating any potential aerosolization, we try to maintain the lowest FiO2 to maintain an oxygen saturation of greater than 90% in these patients. We don't need to be super oxygenating them unless they're pregnant or unless they're kiddos. A SAT of 90 is fine. If they fall into those other two categories, a SAT greater than 94 or 95 is what we target. I don't know why there's dollar signs in that box, but I'll fix that. In terms of intravenous fluid, unless there's sort of hyperperfusion signs, then very judicious or even restrictive fluid administration is warranted. And that's because if these patients do decompensate, then ARDS is what we're going to be battling, and restrictive fluids is part of the tenets of treatment of that disease process. If you do suspect that there's concurrent a bacterial source of infection, then you should treat that accordingly with antibiotics, but there's no current evidence or recommendation in any guidelines for routine administration of antibiotics in patients you suspect only of having viral illness. And then if they come into hospital and they require oxygen, dexamethasone saves lives. So dex 6 milligrams, either orally if they're tolerating or IV if they're not, daily for a maximum of 10 days once they require any oxygen to maintain their oxygen saturation greater than 90%. And that's a strong sort of level A recommendation. In terms of antivirals, and that's basically all you hear about on the news besides vaccines, if they are COVID positive and they require any oxygen, sort of low flow or greater, and patients can be considered for initiation of remdesivir. We'll talk about the evidence in a couple of minutes. There's an order set in I3 under remdesivir that makes you check their ALT before you start it. And the regimen is all included, but it's written here in the algorithm as well. And if there's influenza circulating, then they should probably be concurrently treated with oseltamivir, since they're either at risk or they're already sick. And that can be discontinued once their influenza swab is negative. And I don't know if everybody read the communication from Public Health. I think it was, must have been yesterday. That said they're going to start testing for concurrent influenza and all the nasopharyngeal swabs. We just have to indicate if we want RSV in long-term care patients and the kiddos. So that's the evidence for dexamethasone. The Recovery Collaborative Group did a randomized controlled open label multi-arm trial looking at a number of potential therapies for COVID-19. Dexamethasone so far being really the only one of the ones that they tried that showed benefit, but it did show benefit, and that benefit was mortality. So it's pretty important therapy to be instituting initially. In the early days, we were saying that only people with COPD and asthma probably should get steroids. Now, basically anybody who requires oxygen is going to benefit from dexamethasone. And the benefits with respect to mortality increase the sicker they are. So vented patients need the dexamethasone more than the low flow oxygen patients, but everyone will benefit. And in the other arms, they did sort of debunk conclusively the hydroxychloroquine theories and lopinavir theories. And so we won't talk anymore about those, except for that we won't talk about them again. And this is the figure out of the recovery trial that sort of highlights in visual representation the mortality benefit of dexamethasone. So you can see that sort of the no benefit or equivalence line at 1, the patients who are mechanically ventilated stand well to the left of that line. And the patients who receive low flow oxygen are a little bit sort of approaching 1, but there's still a significant benefit. And then the patients who are not on oxygen lie on the right side of the line. And so there was no benefit from dexamethasone and oxygen in the patients who didn't require oxygen. So you don't get it unless you're requiring oxygen, which is probably most of the patients we're admitting. And so onto the antivirals. The National Institute of Health did a multi-centered international double-blind randomized controlled trial of just over 1,000 people and randomized them to either receive the remdesivir treatment that is in the treatment box that we just reviewed versus placebo. And the primary endpoint that they were looking for was time to recovery. They did demonstrate an overall benefit with respect to clinical signs of recovery in all comers. So you're 1.2 times as likely to be recovered by day 10 if you got remdesivir compared to day 15 if you didn't. And the patients with low flow oxygen had a statistically significantly better odds of recovery than the whole group altogether. And so there is no statistically significant benefit of remdesivir in patients requiring high flow nasal oxygen or mechanical ventilation, but they weren't powered for that subgroup analysis. So it's not that there was harm, but there was no benefit in those groups. And so the guideline recommendations from the National Institute of Health says it's optional in the high flow nasal oxygen patients and the mechanical ventilation patients to institute remdesivir therapy, but there's a strong recommendation for treatment in any patient who requires oxygen in-house. They looked at a bunch of other secondary outcome measures like news scores, length of stay, days on the vent, oxygen requirements, and mortality. And the confidence intervals for all of those things sort of overlapped. But again, they're secondary outcome measures. Interestingly, the adverse event rates were significantly lower in the treatment group than the placebo group. So while it's an expensive therapy, it's not really causing patients a whole lot of harm if they get it. And so if they meet the indication, which is they have to have a positive swab and they have to be on oxygen, then it should be instituted. Now, that's not going to be a huge proportion of our patients unless they come in with a known result, positive and decline in the community. So we won't be starting it a lot of the time, but if we get those patients, there is benefit and we should be starting it. And as I mentioned, once we get documentation that influenza is circulating in our community, and probably all of these patients who are suspect COVID-19 are also suspect influenza, and they should be treated concurrently with those tenofovir until you know otherwise. Just a reminder about conscious proning in patients who are not mechanically ventilated. If they don't have altered mental status or any contraindication from a respiratory distress perspective or physical perspective, patients can be encouraged to do this themselves while they're awake. And if there's any suspicion that people won't tolerate it, probably should not be laying them on their belly. But it will improve VQ mismatch and hopefully mitigate further decompensation. And this is how patients can be instructed to do it. This document is also in our SOP on the website. And this guy that's photographed here is one of my best friends in the whole world, and he was admitted with COVID-19. Interestingly, had 3 negative swabs before his sputum was positive for COVID. He was admitted for 14 days from day 10. So a really delayed onset, but he felt symptomatically at the end of his 2 hours in a position that he was starting to get dyspneic, and so he knew when time was up, and would change his position, and said absolutely from at least a symptomatic point of view and also an oxygenation point of view, because he would watch his sats because he's an emerge shock too, that it absolutely makes a difference. Now that's anecdotal, but I thought I would share that anyway. If they're sick, so any altered mental status and organ dysfunction, super tachypnic or not breathing enough, significantly hypoxemic or tachycardic, then obviously they get critical care, bloods, cardiogram, portable chest x-ray. They're, I guess, in room 24 trauma for now because we don't have anywhere else to put them. And if you're resuscitating someone, it is okay and suggested to try to superoxygenate them. So try to get their SATs above 94 before you intubate them. Be judicious, but correct hypoperfusion with smaller than usual aliquots of fluid. Again, if these patients are sick, they're probably going to get into ARDS, and fluids are not a friend of ARDS. So smaller aliquots of boluses and reassess really frequently. If you think they're getting volume overloaded, or it's not making any difference, and it's time to move on to additional therapy, which we all know how to resuscitate sepsis. And same thing goes for kiddies. So small aliquots of fluid frequently to try to correct hyperperfusion, but if you're not getting any benefit or they're getting fluid overloaded, then hold the phone on that. These patients probably should get concurrent antimicrobial therapy for pneumonia, pardon me, because they're sick, and we know that early antibiotics, if you're wrong and it's not COVID and it is bacterial pneumonia, it's going to reduce their mortality. And so the guideline antibiotic, you could give them piperacillin tazobactam, or ceftriaxone azithro would be the recommended sort of semi-directed therapy that's not the big bomb of pip-taz. These patients should all get dexamethasone. As I mentioned, the mortality benefit increases the sicker you are from COVID. And so they should definitely get it. And then the same caveats apply to remdesivir. So if these patients are going down the road of mechanical ventilation, there's no proven benefit of remdesivir. Expert consensus would suggest that it's an option, but we don't necessarily know that it's going to help them. We don't know that it's going to hurt them either. It probably isn't, based on the evidence that we have. And they should all get Tamiflu. So summarily, be careful about fluids, be conservative about the flow of oxygen that you use to mitigate risk to the team. Basically, anybody that's admitted and gets oxygen gets dexamethasone. If you think they've got a concurrent bacterial source, treat them with antibiotics, but if you don't. And once we get flu circulating, everybody probably should get Tamiflu. And then remdesivir, if they're COVID positive, they get admitted and they get oxygen, then that should be considered sort of free up our hospital beds. And things that we don't have any evidence for, we're never going to talk about again. Hydroxychloroquine, ivermectin, lopinavir, convalescent plasma. That's still a moving target in the literature. People are still looking at that. So I won't say we won't talk about it again, but we're certainly not going to start talking about it. We don't even know where we would get it here. We haven't had enough cases. If you're looking for the algorithm and the SOP and the handouts and all of that jazz, it's in the COVID-19 tab on the website under clinical management, as opposed to all the rest of my algorithms, which are on my own program page. And it won't help you if you're in room 24 because you can't haul out your phone, but all of the COVID guidelines, as discussed here, are also in the Spectrum app, which you can download from wherever you get your apps. This is a Horizon resource that's endorsed by Infection Prevention Control and Infectious Diseases. And so you just follow the homepage to guidelines, select COVID-19, and then scroll down to clinical management, and it'll take you through all of that stuff. And do all the things to keep ourselves safe, and really hope that these numbers in Moncton aren't reflective of what's going to happen in our community, because the rest of the world is really scary right now. I'm happy to take any questions, comments,